Hello and welcome to the second half of our skeletal system vodcast. Now we're looking at the appendicular skeleton, having looked at the axial skeleton in the previous vodcast. To start off with, we look at the bones of the upper body. Remembering the appendicular skeleton, if we flick back up a couple of slides, the bones of essentially the limbs, and not just the limbs but also including the pelvic girdle and the two shoulder girdles. You'll notice that we've obviously got the humerus, we've got the bones of the shoulder here with the clavicle and the scapula. We've got the pelvic bones, the ilium, the ischium, and the pubis. You'll notice that the bones of the lower arm and the bones of the lower leg are actually made up of two bones. This provides many more attachments for the carpals and the tarsals on these bones, much more room for ligament and tendon attachment, which means that these particular joints, the wrist and the ankle, can be much more flexible or maneuverable, I guess is a better way of describing it. If we just go back to our original slide, we'll see that there's a substance called an interosseous membrane, which provides extra stability between the ulna and radius, and unsurprisingly also between the tibia and fibula. Those are those two bones in the lower arm and the lower leg. The bones of the wrist, we've got two rows of four bones. They're made up of short bones called carpals. The distal row articulate with the metacarpals of the hand, while the proximal row articulate with the bones, the radius and the ulna. And again, just like we talked about, I think, in the previous vodcast, when we talk about the phalanges, we're talking about 3 bones per finger and 2 per thumb, and 3 bones per toe and 2 per big toe. So when we talk about the 206 bones that we need to know, a good bulk of them are actually just called phalanges for the level of our study. Continuing on to our lower body, we've got our bones of the hip, with our pelvis. Like I said, the ilium, the ischium and the pubis make up the bone that we might collectively know as the pelvis. And the pelvis articulates with the sacrum and the axial, the sacrum and the coccyx to essentially attach the appendicular skeleton to the axial skeleton. And then obviously the appendicular skeleton continues on from there with the bones of the upper leg and the bones of the ankle and the foot and the lower leg. And so we'll fly on through here. Now, with our bones, they come in a variety of shapes and sizes. We arrange them pretty much into 4 succinct groups. We've got the long bones, the short bones, the flat bones, and the irregular bones. Long bones are usually reasonably cylindrical. They have a shaft and then they are enlarged at both ends. The enlargement at both ends, I've got a little bit of a why question there, but the enlargement at both ends is because of the cancellous bone, which is a lighter type of bone. The cancellous bone has spaces in between the bone tissue where red marrow allows for the process and production of red blood cells. All right, so the red marrow is in those spaces in the cancellous bone. But because it's a lighter bone tissue, it means that we can have a bigger bone area, which then provides much greater surface area for the attachment of tendons and ligaments, making for a much more stable joint, and also allows for muscles to be stronger. It's no point having strong muscle tissue if the tendons that are attaching them to the muscles are really weak, in the same way as having a car pull another car that's got a really powerful engine, but we're only attaching the two cars together with a really thin, easy to break sort of rope. All right, so we obviously want really strong chains there, and the tendons also, if we're going to have strong muscles, need to be very strong as well. Short bones are smaller and cube shaped. Normally they're as wide as they are tall, and that's a good way to look at them, and usually articulate with more than one other bone. So we think of the carpals with the 2 rows of 4. There's obviously a lot of articulation going on there. Generally, short bones, and where short bones are located, allows for lots of movement. Flat bones normally have curved surfaces, and flat bones, because of their flat nature or their slightly curved nature, allow for a lot of area for attachment of muscles and tendons and ligaments, and are usually associated with joints that provide a lot of movement in a lot of different directions. You think of the scapula in the shoulder, and you think of the bones of the pelvis in the hip, and we think about how much movement the shoulder joint has and how much movement the hip joint has. A lot of that is to do with the fact that we have a flat bone in the area where we can get lots of different attachments for ligaments and tendons happening. Irregular bones are bones that have specialized shapes, so they sort of fit in their own area. So bones like the vertebrae are great examples there, as well as the sacrum and the coccyx. They have very, very unique shapes. We also have a little section here down on sesamoid bones. Sesamoid bones are any bones that are completely surrounded by tendon, so they don't actually articulate strongly with other bones. So the patella is obviously a great example, not obviously, but is an example of a sesamoid bone. It's surrounded by the tendon of the quadriceps. And so it articulates in a little bit of a different way to how maybe some of the other bones in our body might articulate. And there are other types of sesamoid bones which you can look up on Wikipedia really easily. The structure of bone. Now, we're looking here most specifically at the structure of a long bone, and hopefully you remember back to our little lab where we were looking at some beef bones. But here we can see we've got that spongy bone or that cancellous tissue I was talking about. It's a little bit pockmarked. Those pockmarks are actually filled in real life by the red marrow, and that's where the production of red blood cells takes place. So it's a really, really important structure within the cancellous tissue. On the outside of all bone, and particularly through the shaft area, we have compact bone tissue, which is much more dense than the cancellous bone and a lot stronger. And so that's why the bone can be so much more narrow here, because it's actually surrounded by very, very strong bone, a lot stronger than the bone up here. The strong bone here is protecting the medullary cavity, which is where yellow marrow is stored. Yellow marrow is essentially fat, and it's a really good energy storage spot for the body. Now, on the outside of the bone, we have the periosteum. It's like the skin of the bone. You can see this fold back here. It's the first layer of bone tissue. On the inside of the bone, or the last layer before we get to the marrow cavity, we've got the endosteum. All right, so they're two, I guess, layers to remember. The outside layer is called the periosteum, and the final inside layer is called the endosteum. Then going further down, we've got our epiphyses, which are 1 and 2. We've got the proximal end, which is the end closer to the midline of the body, and we've got the distal end, which is the end further away from the midline of the body. On these distal epiphyses is the articular cartilage. Now, the articular cartilage plays a really important role in making sure that the joint moves really well. The articular cartilage should completely surround the head of, or the epiphyses of the bone, so that at no stage is there contact between bone tissue from one bone and bone tissue from another bone. Instead, it's the contact of two articular cartilage surfaces. It makes for a much more mobile and freer moving joint, and a lot of osteoarthritis is in relation to the fact that the articular cartilage has been worn away to some degree, whether it be no cartilage at one end and cartilage on the bone below, or in really extreme cases, no cartilage on either epiphyses, so we have a situation where it's bone on bone, and that can lead to a significant osteoarthritis, or feelings of pain and swelling and inflammation and difficulty being active. Moving on. We've got different types of joints obviously in the body. Articulation is simply where two bones come in contact with each other, or more than two bones, and we call that a joint. Joint movement and stability is really important. Generally, the more mobile the joint is, the less stable it's going to be. Mobility suggests that there's increased movement allowed by the ligaments, increased movement allowed by the tendons, and when that's the case, well, then we have an increased chance of there being an injury, because the bones and that area of the body could potentially move further than is originally designed, and so we could end up with a dislocation of some description. All right, so generally the more movement, as I said, the more the risk of injury. So the shape of the bones and whether they interlock with each other or not is going to influence how mobile the joint is. The area over which the bones are in contact is going to influence the flexibility of the ligaments and the influence of other soft tissue structures. So if we've got really weak muscles in an area, well, then there's going to be an increased chance of dislocation. If we've got stronger muscles in an area, well, there's going to be a decreased risk. And that's why, as part of rehabilitation from any dislocation injury, it's going to be some sort of weight training to increase the muscle tone and muscle strength around that joint, to try and benefit the joint by having the muscles and the tendons assist the ligaments in trying to keep the bones in the right place. Ligaments are to be remembered as being the joiners between bone and other bone. All right, so that means they generally have to pass over joints. So if we think of a knee joint, we'll have one ligament running from the femur all the way down to the tibia. Ligaments generally resist movement, and so they're really stable, and they're not very flexible at all. That said, they're not impervious. So if we do offer a strong enough force, well, the ligaments could be stretched. If it's a really strong force, the ligaments could be torn. That's consistent with rolling an ankle, and it's consistent with tearing ligaments in an ankle by stretching the ligaments further than they're able to go. Now, unlike muscle tissue, our ligaments are not elastic. That means that their ability to stretch is really poor, and their ability to regain their shape once stretched is really poor. And that's why it can take many weeks, if not even longer, for a stretched ligament to heal. The ability for it to return back to its original shape is very, very poor. So much so that, in fact, that if you continually stretch a ligament, you might find that it never regains its original shape, and that then would put you at a very high risk of having an injury occur at a regular basis, and it might be such as an unstable ankle or an unstable knee, or an unstable shoulder. And if that were to continue and obviously limit your performance in a particular sport, that's where you might go in for an operation and have what's commonly termed a reconstruction, where the ligaments are going to be chopped and shortened to accommodate for the fact that they've managed to get themselves stretched and longer. So we actually need to trim them and essentially re-tie up the joint so it's as tight as it previously was before the original injury. So our types of joints are our fibrous joints, our cartilaginous joints, and our synovial joints. We're mostly interested with our synovial joints because they're the joints that allow lots of mobility, and obviously physical activity is dependent on mobility. So within our joint, we've got lots of distinctive features. So we can see here we've got our ligaments joining one bone to the other. We've got our articular cartilage at the ends of the bones, protecting the bone surfaces from one another. We've got the joint cavity itself, which is going to be filled with synovial fluid, which, for lack of a better term, is simply oil. It's just going to lubricate the joint and allow these surfaces to move across each other much more easily. We've got a fibrous capsule, which is essentially the joint capsule, which sort of makes sure that this synovial fluid doesn't leak out into other parts of the body, and because if it does, it means we have to produce more of it, and obviously by keeping it trapped, we don't, and so that's a really good mechanism. And then on the inside of this fibrous capsule, or the joint capsule, is the synovial membrane, and the synovial membrane secretes or creates the synovial fluid. So as the synovial fluid wears out and we need more of it, that's going to be the synovial membrane that's going to allow it to be released. Also inside our joint we might have fibrocartilage, which might be a bit more than the articular cartilage, particularly in the joints where there's going to be significant loading. So we'd be thinking about the joints like we'd be thinking about joints like the knee, the ankle, the hip, all those joints of the leg. And then also we have things called bursae, which are small fluid-filled sacs which sort of sit in between multiple tendons. So if you think of the ankle or the hip or the shoulder, which can allow movement in all sorts of different directions, it wouldn't be uncommon for tendons or ligaments to be crossing over each other. And if they're being shortened and lengthened, well, they're going to be rubbing against one another, and that might cause friction and that might cause irritation. Where there's going to be points where ligaments or tendons or both are going to be rolling over the top of each other, there's generally a bursae there, and that bursae essentially limits the friction or limits the rubbing friction between two ligaments or between two tendons or between a ligament and a tendon, and that just makes for an easier movement of the joint. Okay, so that's the role of a bursae. We've got our types of synovial joints. We've got gliding joints, we've got hinge joints, we've got pivot joints, we've got condyloid, saddle, and ball and socket. You can easily read there the movements allowed by these different types of joints. You can see over here in this diagram some really, really simple examples of where we would find certain types of joints within our bodies. We've got a hinge joint in the shoulder, for example. Important to realize, though, that when we talk about the wrist and when we talk about the ankle, that we have many joints located in that area. So remember, we have the joint between the carpals and the radius and ulna, and then also another joint between the carpals and the metacarpals. The same down here, the joint between the tarsals and the fibula and tibia, as well as the joint between the tarsals and the metatarsals. That said, there's also the joints between the tarsals themselves and the carpals themselves. So potentially lots of different types of joints. Hopefully that all makes sense. Obviously any questions you let me know, but I'll see you soon.